Time.
Yeah,
Invite.
you ready to
Of
get started?
course.
All right, so I'm going to introduce you and
Okay.
then you can just take it from there. Did you get the questions that the Healthcare Club submitted?
I did. I'm trying to pull them up just so I can read them off after um, I kind of do the intro part. Bear with me just a second. I always kind of joke that I run a tech-enabled services company and I can't operate tech. It's kind of ironic. So, all right, there. I have them up now.
Yeah,
Perfect.
you're nothing if not adaptable, aren't you?
That's right.
Yeah. So good morning, everybody. I hope everyone had enjoyed the ESPYs last night. It looked like it was a fun time. So we're very happy to have Travis Messina with us today. He graduated in 2008. I could go on and on about Travis. I remember the day he walked into my office. He wasn't even, you weren't even an agent, were you? You were like an assistant to an agent at William Morris. And he said he wanted to be an investment banker. And I remember thinking, oh boy. But I have rarely seen somebody with that much drive and ambition. And he has had an amazing path since coming to Owen into having founded his own company now. So I'll let him talk through his trajectory, but he's done a lot in 12 years since Owen, and we're all very proud of him for all that he has done and his dedication to us and his family and everything. He's just been a great ambassador for the school. So I'll turn it over to Travis because thanks to all the folks that sent in questions, I believe there's things to talk about, and certainly he can give us perspective on what's going on right now in the healthcare industry. So I'll just turn it over to Travis.
Perfect. Well, thank you, Emily. And those are insanely kind words. And you were instrumental in helping me do that. And so I will forever be grateful to you and the team at Owen. I saw Sylvia somewhere on there when I was logging on. So Sylvia was a big part of that as well. But maybe Emily, if it works for you, I'll try and do this briefly. Hey, Sylvia. I will give my quick background, that path that you described, talk about Contessa just briefly, and then pause and see if there's questions, and then maybe jump to the questions that were submitted from Courtney, if that works. Does that work for you? Okay, perfect. As Emily mentioned, I had a very different background and path to where I am today. It was not planned in the slightest. I always joke that I kind of Forrest Gumped my way to this seat and this position with this team. I grew up in Louisiana. I went to UGA undergrad, was a finance major there, had gone to New York to be a summer analyst in research. And when I went back to Georgia for my last year, to be totally honest, I met someone and, we kind of hit it off, and she said, I'm not moving to New York, I'm going to Nashville. And this was in 2002. For those that are not from Nashville, it was a lot different in 2002 than it is now. And so on a flyer, I just said, you know what, forget about New York, I'm just going to go there. Followed her here, and as Emily mentioned, there were no investment banking jobs in 2002 in Nashville. This is right after 9/11. There was one investment bank called J.C. Bradford, but it had been acquired by what's now UBS. And so I went to train as an agent at the William Morris agency. You actually start in the mailroom. And so I pushed a mail cart around and would get agents laundry and do things like that. And after about 3 years, when I couldn't, while it was a lot of fun, I wasn't really using my brain, so to speak. And so I was like, you know what, I'm going to go back to business school and try and get back into the finance world and go back into investment banking. As Emily mentioned, came back. I worked really, really, really hard, and I did not get a single offer for any of my summer internships from any of the investment banks. And so I took a job with Bank of America in the commercial banking group in Houston. Went there, worked insanely hard. First one there in the morning, last one to leave, got the offer, and then I was able to parlay that into a couple of offers for middle market investment banks, and ultimately decided to go to SunTrust Robinson Humphrey in Atlanta, and was in the mergers and acquisitions group for about 3 years. Started as a generalist, but then pretty quickly got onto the healthcare services track. After doing that for a while, I enjoyed it, but knew I always wanted to do something a little bit different. And so took a job with Vanguard Health, which was an acute care or integrated services operator here in Nashville, backed by Blackstone, run by a man named Charlie Martin. I worked for the vice chairman, Keith Pitts, and would do hospital acquisitions and acquisitions related to our health plan business. And while we were in the process of, building out our company, there was this model that we looked at deploying in our San Antonio market called hospital at home. And I always thought it was kind of interesting. And we were doing all these innovative things at Vanguard. We had piloted bundled payments with CMS. We were one of the first ACOs. And, we were really trying to move down that value-based track when the company was acquired by Tenet Health, which is based out of Dallas. I decided that I did not want to go to Tenet. It was relocating to Dallas, and while I loved the man that I worked for, Keith Pitts, it just wasn't right for me. Coincidentally, Charlie Martin said, "Hey, do you want to come to my family office and do some venture investing for me in healthcare?" I said, "Look, I came to Vanguard to get out of the investing world. I have this idea to make hospital at home a sustainable business. But it's never been reimbursed. It's got great clinical outcomes, only operated in a pilot-like environment. And if we could do what USPI and surgical care affiliates have done with health systems to run surgery centers for the hospital at home model, I think we could be really successful." So Charlie, being kind of the consummate entrepreneur, was like, "That's a great idea. Why don't you come to my family office, write your business plan, make some investments for me. And if your business plan is worth a crap, I'll give you the seed money and you'll go from there." And that's ultimately what happened. So for all of 2014, I wrote the business plan of Contessa, where the whole idea is to joint venture with health systems to run the hospital at home program. Hospital at home, if you think about a hospital, you have all the various floors. About 40% of admissions for a hospital are for general medical complications. Things like congestive heart failure, COPD, pneumonia, cellulitis. So we target those conditions and we identify those patients when they show up in the ED most typically. We send that patient home and we replicate all the services that they would get in the hospital over a 30-day episode of care, leveraging hospitalists, nurses, telehealth, infusion, and services of that nature. We thought that health systems would want to do this in an episodic bundled payment, because typically a hospital actually loses money every single time they admit a patient for a general medical condition. So if we could take that patient, send them home, and make it a more profitable episode or treatment for that health system, then they would be better off, and they could position it as a unique service line. So that was the goal. Like I said, wrote the business plan in 2014, did the seed round, kind of quit my job at Charlie's place in January of 2015. Got our Series A with Blue Cross Venture Fund in November of 2015, there's a funny story behind that. I did a Series B with Nora Mosley, a C, and then we actually just closed, and we haven't announced it. Thankfully, we closed it in January, a $32.5 million financing that was led by Optum and Deerfield, which is a $10 billion fund out of New York. We've got just under 100 team members now. We will launch our 6th market next week in South Carolina. Our partnerships are Marshfield Clinic in Wisconsin, Mount Sinai in New York, which has been interesting these last few weeks. St. Thomas here in Nashville, Common Spirit in Phoenix, Highmark Health in Pittsburgh, and then we launch with Prisma Health in South Carolina next week. We are under letter of intent for a 7th system. And we just found out last night we'll move to letter of intent with an 8th system. So continuing to grow. Definitely some challenges in the COVID-19 era, but I think the long-term potential of Contessa is pretty strong, because we do render hospital level care without preventing patients to the bad things that they can experience in a hospital. So I'll pause there. I wanted to give kind of the perspective. I'm an open book, as Emily knows. I'll say whatever's on my mind for better or for worse. But before I can either tick through the questions or I can pause there, Emily, Courtney, see if that sparks any initial questions. I can just go through the list. Let me just go through the list. Okay, perfect. The first question that I received was, how will the silent rapid spread of C-19 impact healthcare delivery processes in the future, such as greater precautionary measures by practitioners? I think that this is something that we, as soon as this happened, again, being partnered with Mount Sinai in New York, it gave us a front row seat to the most heavily impacted area in the world. And so we thought, geez, if this happens there, what are the chances that it happens in all of our markets, and how does that impact our business? And so probably the biggest change to healthcare delivery, so as it started with Mount Sinai, prior to the government mandating that health systems eliminate elective procedures or pause elective procedures, they thought, oh my gosh, we're going to be inundated with patients and we have to just put the program on steroids to treat, to create capacity, right? This is before they had talked about putting patients in the Javits Center and hotels and all these other things. So how do we amp up the program? Then they eliminated elective procedures, and that created a ton of capacity. But then at Mount Sinai, there were so many COVID patients, they got back to capacity, which was pretty scary. But the biggest change I think that we've seen is twofold. One, ED or emergency room utilization has disappeared. If you look at HCA's earnings, they were, their ER visits for the first quarter through the second week of March was up a couple of percent, I think up 5 percentage points compared to the same period last year. For the last 2 weeks of March, it was down 30%. And we've seen health systems across the country down 30%, down 40%, down 50% in some markets. There is no one going to the emergency room, largely because of sheltering in place, but also because patients just are terrified to go to a hospital and possibly be exposed to this virus. Now, whether that's a short-term issue or a long-term trend, that could fundamentally change the way hospital care is consumed. And along those lines, telehealth utilization has just absolutely skyrocketed. Teladoc is another publicly traded company. I think it's the only pure telehealth company that's publicly traded. And if you look at their downloads for their app, like week by week, it was up like 100%, starting in March. So I think that this virus, it already has impacted those two trends as it relates to healthcare delivery. Again, whether that's prolonged remains to be seen. But I think, especially on the practitioner side in telehealth, they realize, hey, I can do this, I can get paid for it, and I can have pretty good outcomes. So I'm not going to be as scared of it. And so I think you'll see an increased utilization in telehealth. Does that spark any questions? Emily knows I don't like to just talk, so I'm kind of an interactive person. So, and you guys just interrupt me, but I'll just keep on going down the list.
Actually, Travis, I have a question.
Hey, Dan.
Hi. One, thanks for doing this. I have a question about Contessa's model when it comes to COVID-19. Is there any special equipment that you're equipping your staff with to take care of patients for this epidemic?
Yep. Short answer is no. Most patients just need oxygen. I hate to oversimplify it, but so long as they have, assuming that they haven't gotten to the point where obviously they need, full respiratory treatments in the form of ventilators. But primarily we send the patient home with telehealth, which has a pulse ox, it's got a blood pressure cuff, a virtual stethoscope, so nurses can hear the auscultations of the lungs, which is kind of most important because you don't want them to get to pneumonia. So it's mostly just oxygen treatments.
Okay.
Okay. The second question was, how are you training family to be more effective resources to care for the loved ones and be extensions of your clinical case management team? It is not an if a patient does not have appropriate family members to support them, it is not an automatic exclusion for our program. In fact, when you get into different lines of business as it relates to a health plan, so commercial versus Medicare Advantage versus managed Medicaid, there are very strict rules in terms of what services you can or cannot provide, because it could be viewed as inducement. And so in some instances, we can rely upon the caregiver, but if the patient can safely take care of or handle acts of daily living, you don't need family support. So we try and not rely on family members, just because if you did, it would be a serious rate limiting factor. In terms of how has COVID-19 affected Contessa's business model and how has your strategy changed in the face of the pandemic? I mean, we're assessing it daily. We haven't actually come to hey, we're going to fundamentally change our business. The biggest one goes back to how has delivery changed, that first question, because 85% of our patients are captured in the emergent or identified in the emergency room. Historically, when patients need hospital level care, they go to the ER. So naturally, this has hit our business. I mean, a lot of health plans have realized the value of our model, and we've actually signed more health plans, I think, contracts in the last 3 weeks than we've signed in like the last 2 years. But they're really just setting up for the long term. As we mentioned, there's a couple of health systems that have wanted to move to partnerships since this started. So again, seeing the long-term value, but the near-term impact, we have had a softness in our volume. You've had just obviously the lack of ED utilization has impacted us. So the main thing that we're trying to assess is whether or not there's an ability to identify patients in the community. We always thought it was kind of an oxymoron that you needed a hospital partner to have a successful hospital at home program. So that's probably the biggest strategic impact that we're trying to assess as it relates to our model.
Along those lines, are you looking to use like telehealth as a triage point? Because it seems like if the ED is dropping, telehealth's going up, there's got to be some same store displacement going on there.
That's right. That's exactly right, Max. I mean, that's the main one that we're looking to. Are people or patients rather using telehealth as the entry portal, right? Everyone always talks about the front door to healthcare. Where's the front door and how do you create that? And that stickiness. There are groups that are fully delegated physician practices. So Optum is one of the largest employers of physicians in the country. And in many markets, they take delegated risk. So they get paid a per member per month payment, and they manage those patients' care underneath that capitated arrangement. If you were to ask those groups prior to COVID-19, what percentage of their patients call their doctor before they need a hospitalization? They'd say it's like 2 or 3%. None. They always just go to the ED, no matter how great. And people, like, if people say they have great engagement, they're lying. It just doesn't happen. But now, because of this, like, we are looking at, can telehealth be that portal? It changes the delivery model, obviously, because you don't have the full diagnostic capabilities that you would have in an ED. But we are seeing that, and that's probably the primary one that we're going to, Max.
Very cool. It seems like it'd just be more attractive too, because so much of the advice is stay home. Just take care of it and stay home.
That's right. I mean, we've had, like, as soon as it started happening, we had just signed a contract with a new health plan in New York, and the primary care physician said, hey, I just saw my patient. They need to go to the hospital. I do not want to send them to the ED, and they don't want to go to the ED. We said, well, look, if you want them to be treated at home right now, this is the only way that we can treat them. So they sent them to the ED, and they had it cohorted so that your COVID patients were over here and your non-COVIDs were over here, which was possible at that time. It was not the case a week later, but we were able to solve for that. But it is changing. Next question is about supply chain. How do you anticipate supply chain for personal protective equipment, such as vents, to change in the future to prevent shortages that have been experienced in the global response to the pandemic? I don't know that I'm appropriately, I'm not as close to this. I mean, obviously it was a massive issue for us out of the gate. I mean, I kind of think of this like a 500-year flood. I mean, that's the only thing I can think of. There's a shelf life on that equipment, right? On a lot of that equipment. And so you can't stock up for it in the event that you have some, global pandemic, because it's not effective. And especially with the financial hit that health systems are taking, they're probably, once this all subsides, they're not going to go out and spend a lot of money. So I don't know what massive changes you'll see there. You obviously have the Wartime Act to get non-ventilator manufacturers to spool it up, but I don't know that you'll see much to solve for that after the fact, but that's just my opinion. Next one is, are hospitals quicker to discharge patients that may have had longer length of stay before COVID? Absolutely. Especially, it depends on what their capacity constraints are. So one of the things that we started doing with Mount Sinai, they used our model to allow patients to complete their hospitalization at home. So as more and more COVID patients started coming into the hospital, they needed every single bed that they could have. And while some patients weren't ready for discharge, they knew if they sent them to us, we could allow them to complete that hospitalization at home. It started with non-COVID patients, and then it moved to COVID patients once they were stable, because some of them's length of stay was getting absurd. It was north of 10 days. But that's definitely, it's interesting, right? It brings up a much bigger point, because most hospitals are reimbursed by a DRG, which they get paid that payment. And so long as the patient doesn't hit like a massive outlier in terms of their length of stay, the payment doesn't change. And way hospitals make money, after about your second or third day, your incremental dollars that you make are so small that it's kind of it's not a major focus. If it's a surgical patient, you can get them out same day. Absolutely. They'll focus on doing that every single day, because all that margin just drops to the bottom line. But once a patient has been there about 2 or 3 days, really like 3 to 4, then the incremental dollars are not as much. So there's not as much of a focus to reduce the length of stay. If they were paid a per diem, which some of those delegated risk groups do, then they want to, it's actually kind of perverse incentive. Right? You want to keep them there as long as you can, but those delegated risk groups are working to get them out. So you kind of have conflicts of interest there, but in a DRG world, they are, especially when they're capacity constrained, trying to reduce that length of stay. Next question was, with patients wanting to get in and out of hospitals faster, especially with awareness surrounding the pandemic, are many hospitals willing to connect with Contessa? So yeah, it's exactly what we were just discussing. I think a lot of them are realizing, they're not going to want to come to us anymore. We have to come up with an alternative. And the analogy that we often use is that, and I used it at the beginning, Contessa is a lot like surgery center companies. In fact, my mentor, Charlie, that I mentioned, he sold his first business to HCA in 1979 or 1980. And his partner went off and started Surgical Care Affiliates, which is now owned by Optum, like many other things in the world of healthcare. And it was a surgery center company. He was going to partner with physicians and hospitals to run ambulatory surgery centers. And so Charlie Martin went to Tommy Frist and said, hey, Tommy, Joel's gonna go do this surgery center thing. They got these new buildings where they're like freestanding ORs, and you can send a patient home the same day after they get a surgery. And Tommy Frist looked at Charlie and was like, that's the stupidest thing I've ever heard of. Like, surgeries only take place in a hospital. And fast forward today, HCA owns about 100 surgery centers. And if you look at it, about 2/3 of all surgical volume in the United States is done on an outpatient basis. So, the adoption of surgery centers by health systems, we feel that there's an analogy that there will be a similar adoption of the hospital at home program. Courtney, I just got your message. Courtney just shot me a chat that said, are there thoughts on how to move that sort of patient nudging forward after the current crisis subsides and people may revert back to less efficient ways? I think it's ultimately just patient demand, right? So if you think about how surgery center utilization came about, the payers kind of forced it, because in 1980, only about 7 or 8% of all surgical volume was done on an outpatient basis. And that was largely because it wasn't a reimbursable event. And so as a member of a health plan, you weren't able to go to a surgery center. Well, then all this health plans started reimbursing for it. I think that's the nudging that you'll have. It'll be a part of their benefit design, right? So United now pays us, all national health plans with the exception of one, reimburse us for the program. And they're trying to find ways to incorporate that into their benefit design. So as we become more conscientious of our purchasing of healthcare services, if I can go, when I need this care, if I go to a hospital and I'm going to pay my patient portion, you know, if my deductible's not met, I'm going to have to pay that, or I'm going to have to pay a copay for a hospital stay, or I can go to hospital at home and I have no copay, you know, that's how they're doing the nudging. And so with pretty much all of our partners, there's no member cost share on our program. So I think that's the way to do it. With apps, it's a little tougher just because patient engagement through those types of things still kind of remain low. You know, people don't use them or adhere to them as much as they'd like to. Is that helpful, Courtney? Perfect. The next question was, have we witnessed growing consumer comfort with the idea of home healthcare in the midst of this pandemic? Absolutely. Our engagement rate, like, so when we offer a patient the program, about 93% of the time they accept. And now we even have doctors who are reticent to refer to the program, and the nurses that we have in the ER in our partner systems are like, hey, look, we got 30 COVID patients here. You want to come in here? And so it's not just the patients wanting more home health, but it's the doctors wanting it because they know it's a safer option for the patients. What healthcare sectors do you think have the highest growth potential in the wake of COVID-19? Home, obviously I'm a bit biased, but anything home-based care or telehealth care, I think has the greatest potential. A lot of the digital platforms, and I don't know as many of these companies, but there are a lot of digital platforms, not just telehealth, but that allow consumers to engage with healthcare, you know, via their iPhone or online. Those businesses tend to be doing really well. Bricks and mortar businesses in any subsector are they're hurting right now. Behavioral health. I mean, surgery center companies have shut down. You have companies like USPI, that's a division of Tenet. Right down the street, you have Envision Healthcare, which was AmSurge. HCA talked about their drop in surgical volume. So surgery centers, hospitals, behavioral health, anything that's, facility based is really struggling, while anything virtual is really, really picking up. What keeps you up at night during this time? Emily and I were talking about this the other day. Not much, honestly. I sleep really well. Because now if you asked me that question in 2015 when I started the company, I'd say I didn't sleep for like a year and a half. I was terrified of everything. But then I got to a point where it's there are things that are out of my control. Like I can't control the fact that patients are not going to EDs, and so our volume is dropping. And so it's how do you respond to that, and focus your effort and energy on how you can respond to the things that you can impact on a daily basis. And you'll make progress. And so, I shared that message with my board last week. We had an update call, and I think those that have been in this, either in investing seats for a long time or previously been in operating seats, I can't do anything about the volume. But as I mentioned, we've worked really hard to get a number of payer contracts done. And we've done that because that's in our control. We can work to get those payer contracts done. We can work to create new admitting sites. We can create variations to our model. And so, if I weren't surrounded by a team who could appropriately execute on the things that we can control, then I probably wouldn't sleep. So, that's what I'd say to you guys. I read something, I think I shared it with a friend, that the thing that, concerns me, but I can't do a damn thing about it, so I don't really worry about it, is just the pure printing of money that our government is doing right now, right? They're just, like Emily and I talked about it, when I graduated from Owen in 2008, I was an investment banker right as the financial crisis hit, which was a terrible time to be a first-year associate. And at that time, and this is because I didn't know as much, I went into work every day and I thought I was going to lose my job every single day. And I worried about it. I never slept, but I was newly married. My wife was pregnant with our first child. And that's the same woman that I followed to Nashville, so it worked out. Sorry, my light went off in my office. Hang on. And I called my uncle, who was a managing director at a different investment bank, and he was retired. He was like, Travis, if you're going to get fired, you're going to get fired. There's not a damn thing that you can do about it. So just go into work every day, keep your head down, do your job, and that'll be that. And so, I mean, like, that was my first exposure to resting well at night. And so, I mean, I know you guys aren't asking for advice, but that's one thing that I would say. Like, I've heard about the internships and they're being shortened, and that sucks. It's terrible, but there's nothing that you guys can do about that. So make the most of it. Go in there, do whatever you can in 2 weeks and have an amazing attitude, and people are going to notice that. Because, you know, if you spend time focusing on, well, what am I going to do about the fact that, you know, I don't want to make this political, but someone is doing something as it relates to opening the government back up or opening the economy back up, and, you know, how does that impact me? Like, you know, we have no control over that whatsoever. And so otherwise it's just gonna give you an ulcer. It's gonna make your home life tougher. And so I just try and recommend to focus on the things that you can make better. And the last one was really, was kind of a repeat of the question as it relates to changing the business strategy. So how, if at all, are you changing your future business strategy, having now experienced a pandemic? I mean, I kind of joke and say, like, I think it's kind of sad that it took a global pandemic for her business to really capture the value that it's now capturing. But you know, someone told me, don't let a good crisis go to waste. So, you know, you try and, I think our team has been very good about being deliberate with the strategies that we pursue. A lot of folks, when they start a company, you kind of have the shiny new toy syndrome, and that you're trying to make revenue as quickly as possible so that A, you can survive another day, but B, you make your investors happy. And we have been, and we did this when we pursued our investment partners, like, look, this is a long play. If you're looking to get a quick flip out of this, like, it's not going to happen, right? Like, we're changing the way in which hospital care is delivered, and that's not going to come overnight. And so we've had a very long view, and we've pursued partners that had that same view that we have, and they've been extremely patient, and they've been extremely supportive of management. But it doesn't mean that we just bury our head in the sand and be like, oh, ED volumes are going to come back. So nothing to do. I mean, you have to be diplomatic and diligent in terms of how you assess those things. And so having a good team around you enables you to do that. And so we've got great folks with great health plan experience, clinical delivery experience, integrated health system experience, and that's what makes us effectively assess our strategy, and not just go down a rabbit hole or chase, you know, the shiny new toy, as I mentioned. So those are all the questions. Feels weird just kind of talking, but so I'll pause and hopefully there's some more questions.
Travis, selfishly, I want to ask something. We've had a session with alums who were in your similar spot, graduating during the financial crisis, and it sounds like you do have a head on your shoulders to sort of say, okay, there's perspective in this. For MBAs who are graduating or looking to graduate in a year, any thoughts on building a network, looking at things during this time, unique perspectives to add? This is an unprecedented time, so some strategy around that.
Yeah, and I can only, I guess, really speak to my personal experience and how I handled it, because as I mentioned, I did not have much success in the summer internship process. Emily knows it. Like, it was tough, right, Emily? I got told no a lot. But it was perfect. And I think it was probably what helped, it contributed to my drive. And so what I did in that strategy was, you know, I took what I could get, right? And I worked hard to get whatever experience I could get, knowing that it's not going to be exactly what I wanted, right? I can name all the banks that I applied to that all told me no. And that's what I wanted at the time, but I didn't get it, and that's okay. But I took the experience that I needed and I made the most of it. so that was to go to Bank of America. And I remember flying down to Houston. I was terrified because this was now probably, I don't know, April, Emily. It was getting late in the process. I think I had been married for 3 weeks. I was like, I have a new wife. And I don't have a summer, like, this is not good. And so, like, you know, it was my own little unprecedented pandemic, if you will. And got the job with Bank of America. And then, you know, luckily got the full-time offer, but knowing that, you know, Houston and Bank of America and commercial banking wasn't what I wanted to do. And so I got another internship at the first mod to then parlay that into, as I mentioned, the investment banking experience. And how I did that was took the combination of the things that didn't align exactly with what I wanted to do and created the proper story, right? Because the story is the most essential thing that you need to get the position that you want. And even though it's not, I mean, like, you know, I didn't have the perfect story to get investment banking or to go to Vanguard or, you know, to be an entrepreneur that's raised the capital that we've raised, but it's all about the story. So you take this amalgamation of things and experiences that you have and say, okay, how can I position this to get me where I want to be in the future? Knowing that it's totally fine that you're not going to be where your peers are. If I, like one of my friends, I was just texting with him before we got on, like I constantly used to compare myself, and he's my best friend. I constantly compared myself to him, and he's a managing director at an amazing bank, and like Blackstone's his biggest client. And like he crushes it, and he's been minting money for a decade. And I was like, damn it, why am I not as far as him? Or I look at, you know, a friend, Brad Smith, who was standing next to the president the other day, and you know, he ran Aspire, you know, you can't worry about that stuff. Like you will get to where you need to be on your own timeline and everything will work out perfectly. And so again, just kind of, and it's, you know, it's kind of cheesy, but it's, I told this to Emily and I were talking about this earlier, stoic principles, right? And, you know, making sure that, you know, you respond however best you can respond, other people will notice that. And it was really hard for me to accept that, but I mean, that's why Charlie backed me. And he's even told me that. And he's, you know, an extremely successful entrepreneur. And so I think making sure that, you know, that, hey, it's my own timeline. I can get there, even though it's not a straight path, you know, you can kind of bounce around and that's okay. I honestly think those experiences make you better because then when you're in that seat, you can handle times like this so much better than everyone else. Because if you haven't had adversity, like, you know, it's really hard to deal with these types of things. And so, yeah, the financial crisis was not like this, but going out at that time. And then even when I graduated undergraduate, it was right after 9/11. And so like, I seem to just time these things perfectly or imperfectly, depending on how you think about it, and just know that it will come back around. It's just going to take a little bit longer, and it could always be worse. Like all of you, without knowing any of your personal stories, like I can take you to New York City right now and I can show you things that are way worse than what we are all collectively going through here. So I don't know if that helps, Gordy, but that's just how I kind of try and do things.
No, that's great. Thank you. I think perspective during this time is important, but it's hard to always remember.
Oh. Yeah, and I used to have, like, I'm going to go on a tangent here for a second. I mean, I used to have like a massive chip on my shoulder about this whole thing. I mean, it was huge, just sat right there. And it just, it's not productive. And it's like, why is this happening to me? It's like, you know, and looking back on it, it's so stupid. Like there's no other way to describe it. It's just the most selfish, childish way to view things. It's like, yeah, no one's isolating any one of us out. It's crappy timing. It's just what it is. So,
Travis, I'll just offer an observation. Over all these years, I think balancing, in what you've done really well, is balancing confidence with humility. So I think over, you know, as you've gone through your progression, you've continuously gained confidence in your own ideas, your abilities, but also, you know, you've had to face these difficult situations. So gaining the humility, knowing when to ask for help, knowing when to step back, reassess, change direction. So I think to be successful, and especially in an entrepreneurial venture like you've gotten into, learning from people that you've been exposed to. You're, dealing and having that exposure to Charlie Martin certainly has been pivotal for you, but learning from it, and also at the same time balancing your own, like what you believe, your confidence in your own abilities and your confidence to take the next step out there, because you could have just continued to work for Charlie.
Yeah. Oh, that was the easy way. 100%. And that is one of the greatest compliments I've ever received, Emily, honestly. And like, if you look at our core values at Contessa, humility is one of them. And it's because, especially in entrepreneurship, like you have these startup founders who just have so much hubris and ego, and it's repulsive to me. I mean, and they get theirs in the end. And, everyone thinks that they're great in the interim, and, you can point to just countless numbers of them. And when Contessa goes up to try and win business, right? People ask us questions. We are completely comfortable saying, hey, you know what? I don't know the answer to that, but we'll figure it out together, right? Like having that type of approach, I think that's what creates good partnerships. So I appreciate that. I mean, because while Charlie's been amazing, Keith Pitts, who was the vice chairman, was equally amazing. I mean, I learned probably more from Keith than I've learned from anyone. And he always had the same, get over your bad self, right? Like, and he's an extremely exceptional transaction guy in the healthcare world. And it's just like, you have to have that approach. Otherwise it's, you're gonna fail. You may win in the interim, but eventually it catches up to you.
I have another, it might be the last one, sorry to hold you, but
along
the lines, this is from Kate and Kuma, along the lines of what you're talking about, what were or are other qualities you'd be looking for in building your team from the beginning as you look back on successful folks that you've worked with or that you've pulled into your teams?
Yeah, so, and it kind of depends on, obviously the position, but I think overall there's a couple of themes that we look for. Humility, as Emily mentioned, is probably the most important one. We had someone that came here and less than a week on the job, they were like, oh, I'm too far in my career to do that. It was like, excuse me? And that was that person's last day. It was agreed upon. Like, it was like, yeah, it's not the best fit. Right? I mean, I'm here and all of the senior management team is here, alongside folks doing whatever is necessary. So humility, I'd say we have this relentlessness is another one. Like, you got to run through brick walls. If you want to do something that is truly challenging, like, you can't stop. And so that's it. It's like, man, she runs through brick walls. Like, that's a character, and you can tell that from someone just when you're talking to them. Clarity is like, and these seem like painfully obvious things, but and it kind of goes hand in hand with humility. But it's like, if you just come and be like, I don't have something that particularly relates to that, but here is an instance that could, most likely equate to what you're asking, right? Just being able to take that and give a concrete example in a transparent manner, I think is just, it's absolutely essential, because if you try and bullshit someone, like, they're going to call you out, like, they're going to know, right? And like, so, I know everyone's super smart that's on the line right now, but like, people can see through that pretty quickly. So having that transparency and that clarity is super important. And then the last one, and again, it kind of goes to the relentlessness, is like, you got to close them, right? Like, you got to, like, to be able to say that you have the drive as it relates to whatever you're trying to do. Like, why do you want to be with that team, right? What is it about that team, about that company, about that mission that truly, gets you excited and ready to go to work every single day? Because if you don't have that, when people just come in and it's clear they haven't prepared, or they don't know about the mission, and they don't know what we're trying to accomplish, it's like, okay, if I have two candidates, one that has like amazing credentials, but this doesn't really demonstrate the drive, not necessarily that they'll work hard, but the drive that's necessary to be with that company, or someone who is, not as qualified, but it's like, look, I believe in this so much. I think here are the reasons why this company for me, for the community is good. Like that stands out. And I think a lot of people lose that, even when you go to like a big company, right? I remember when I applied to SunTrust, it's a standard question, but people don't give it a lot of thought. Like, hey, why do you want to come to SunTrust over Bank of America? At the time it was Wachovia or, Deutsche Bank or the others. And I had a very specific reason as to why I wanted to be at SunTrust, in a middle market bank that was headquartered in Atlanta. And that resonated with them. And so you still have the ability to convey that closing mentality, even with big companies. And I think that people don't put a lot of attention, or enough attention rather, on that characteristic that's necessary to make you attractive to the person on the other side of the table.
Great advice. Are there any other questions out there?
Hey, Travis, this is, oh, my bad.
Go ahead.
Go ahead, Lynn.
Got a couple. Nick, you want to go first?
Sure. Travis, thanks for talking. Appreciate you sharing your experiences. Can you talk about your tech side? And I assume that being a provider, you're getting a lot of valuable data. Could you discuss, or willing to discuss, what you guys are trying to do with that data?
Yeah, absolutely. So, I don't know if you want to make a joke about like my tech skills at the beginning of the call. So the core function of our platform is really twofold. One, to analyze and process claims. So we actually pay the providers that are a part of our arrangements. And so since we get paid and pay in a different manner than current fee-for-service arrangements in healthcare, we had to build a claims platform, which people kind of laughed at us when we told them like, oh yeah, we're building a claims platform. They're like, sure, right, that's easy. And then the second primary function is it's a care management workflow tool specifically for our care model. So it tells our nurses exactly what to do, when to do it, and how to do it, unique to our model. And so as it relates to the data question, the thing, and we don't have nearly enough of it yet, right? So we're paying claims for the services that are provided by our caregivers. Once we have enough, we will be able to take all of that claims data, because it's ours, we pay for it. We pay those claims, and be able to tie it to the clinical data that we're capturing. Because most of the time, those two worlds are separate, right? You have insurance companies like Blue Cross that are paying claims to health care providers like HCA. Fully integrated systems like Kaiser or Highmark or the Marshfield Clinic, some of our partners, they have that ability because they own both the health plan and the provider. And so the information that's in the EMR is great, but it's missing a financial component. And so our goal is eventually we'll have both sets of those. And so we'll be able to combine that, which we'll be able to extrapolate in terms of predicting what will be necessary, what is likely to happen from a care perspective, and what can we do to intervene to lower the cost and without jeopardizing the outcome. Is that helpful?
Yeah, definitely. Thanks. Yeah, I'll stop there.
Dan, did you have a question, or anyone else?
Yeah, I had a question. This is kind of specific, but does Contessa plan, or do they have a care model for people who have chronic pain or pain management kind of in the horizon?
Yeah, we don't. We do not currently, and it's not in our current focus. We are really trying to focus on the medical conditions, while you could say that is a chronic medical condition, the rendering of those types of controlled substances to manage that pain is really, really, really dangerous.
Okay.
And so, the whole foundation of our program is built on patient quality and safety. And we just haven't gotten to a point where we can administer those types of controlled substances in the home and without risking patient safety.
Got it. Okay.
I have one question, Travis. I know when you first started, you were focused, this model was going to be focused on orthopedic care.
Yep.
And now you've moved to medical. Can you talk about how that happened?
Yeah. the whole, the idea, so as I mentioned, Vanguard participated in the bundled payments pilot program, which was called ACE demonstration, then it became BPCI. And CMS said to start a bundled payment, you had to have an anchor admission, you had to have an index admission to an anchor hospital. Otherwise, a bundled program or episode could not start. And we just thought that was a fundamental flaw that Medicare was making, because we had surgery centers that could do total joint replacements. We thought, wow, a surgery center is a lot cheaper than a hospital, and the quality is just as good. And we also were working on the hospital at home program in San Antonio. And so we said, hey, if we, why do you have to have that? And so when we started Contessa, it was, let's go after orthopedic surgeons that have their own surgery centers, who cannot do total joints in an outpatient setting. They did have rates, but the utilization in that setting was insanely low, because unless it was a picture perfect candidate from a health perspective, I mean, you'd have a BMI of a certain, type parameter, you couldn't have any comorbid conditions. I mean, like, there was significant limiting factors. And we said, but if you wrap it with this intensive home nursing component or home hospital service, they could get more of their cases out of the hospital and into the ASC. It didn't work for a number of reasons. One, there just weren't, while it's a high unit cost in terms of the cost of a total joint to a hospital for a commercial insurer is really high, there's not a lot of them, right? There's a ton of them in Medicare. And so they were like, yeah, I spend a lot, on a per unit basis, but in the aggregate, I don't spend that much money. They're like, man, if you could do this for medical conditions, we do that every day. So that was the first thing. The second thing were the politics involved. Hospitals really like their total joints. They make lots and lots and lots of money. And one CFO said that he would shoot me if I tried to do that. So, in the interest of self-preservation, I thought, maybe I should focus on medical models first. Interestingly enough, because of COVID-19, the elimination of electives combined with the fact that patients don't want to go into a hospital, ASCs have started calling us and saying, hey, you know what we talked about like 5 years ago? Could we revisit that? Because there's this whole backlog of cases. The hospitals aren't going to be able to service it. Our patients aren't going to be able to get there, and we don't have the capability to send this many patients home. So it may come full circle, but that's where, one piece of advice I received early on is you can't be too wed to your model. You have, especially when you're at the very early days, you have to be flexible in that regard. And so we had always planned to go into medical, but we thought it would be like a phase 2 or 3 issue. It quickly got flipped. We went to
way to be adaptable. What do you think is going to happen with the backlog of elective surgeries?
I don't think it's going to come back nearly as quickly as they're projecting it is. If you look at, if you go back to HCA after the last financial crisis, it took them 3 years to get back to the same capacity of where they were for elective procedures. Like, that's a long time away.
That's a lot of cash too.
It's a boatload of cash.
Yeah.
And like, it's scary, but again, in the bucket of I can't control this, I would say that, that this could be a major problem for health system providers, because, it's not like, and someone used this analogy the other day, they're like, hey, as you're sheltering in place, if your favorite restaurant was closed, it's not like when it reopens, you're going to go back and buy 4 of whatever you're going to buy. Like, that, it's gone, right? Someone's going to need it, but it's just been pushed out that long. And so it's not like you're going to get more and get back to 100%. I think it's going to take a long, long time. And some people have realized, hey, I don't need this service, right? It's elective, it's called elective for a reason. And so I think it's going to take a very long time before that demand comes back, largely because of the fact that you now have, 22 million people that are unemployed. And so as they shift from commercial insured rosters to something else, it's going to cost them a whole lot of money, and they're going to put it off.
Yeah.
And so until the economy rights itself, I think you'll see quite a bit of a lag in that regard.
Wow. Crazy times. We're going to have to bring you back in another 6 months so you can tell us what happened.
Absolutely.
So,
Is there any other questions? I know we got a few more minutes.
yeah, are there any other questions out there?
This was a fun one. Does Travis have any recommended readings or podcasts?
I'm a book person. Although I think, I'm not really a podcast person. So books, I read Leadership by Doris Kearns Goodwin, who I believe Emily turned me on to several years ago. Anything she writes is amazing. It's about Abraham Lincoln, FDR, Teddy Roosevelt, and Lyndon Johnson, and kind of their upbringing, the struggles they faced, and then how they, kind of the times. Is it the person that defines the times, or the time defines the person? So that's an amazing book. Shoe Dog is a fun book. It's about Phil Knight and kind of how he built Nike, the fact that it almost went bankrupt 3 times. Those are probably 2 of my favorite books that I've read recently. And then for pure, just like mind-numbing enjoyment, there's this guy named Don Winslow. It is like trashy, like gangster type novels. Like he wrote one called The Force, which is about the New York Police Department. If you want to like get your mind off of all this crap and like just have pure enjoyment, like that's an awesome. And he wrote one called The Cartel. Amazing novelist. He's got his new book coming out, I think, right now. From a podcast perspective, there's some friends that have one called A Healthy Dose. It's a guy named Steve Krause and Trevor Price. Steve Krause is a partner at Bessemer Ventures, and Trevor runs a company called Oxyon, and he's partners with Andy Slavitt, who used to run CMS, and they have an investment fund. So that's a fun podcast that's about healthcare specific, since I know all you guys are largely focused on healthcare. That's all my recommendations. So hopefully this was helpful. I really enjoyed being here, and I was bummed obviously we can't do it in person. I know I've done it before, and hopefully love to, assuming campus is open in the fall.
Come on back.
Yep.
Thank you so much, Travis. It was great to get caught up and see you, and good luck over the next couple of weeks and months, and we'll see you soon.
Same to all of you guys, and be safe, and really appreciate the opportunity. Talk to you guys soon.
Bye.
Thank you so much, Travis. Appreciate it.
Thank you.
Thank you.
Thank you, Travis.
Thank you, guys.